Technical team. Hello, technical team.
Hello, yes, sir.
Doctor will be joined within a 10 minutes.
Okay.
Wait for 10 minutes, sir.
Hello, sir. When can we expect the doctor to?
Sir, wait for only 2 minutes, sir. Only 2 minutes. सर सुरू करायचं का? सर
हॅलो. हो, चालू करूयात.
हो सर.
हॅलो.
स्क्रीन सर.
आय एम ऑडिबल?
येस सर, येस सर. स्क्रीन शेअर करा सर.
हो, एकच मिनिट.
टेक्निकल टीम.
Yes, sir. If we are live, so we can start. So I would request you to screen share and we can start.
Yes.
हॅलो.
हा सर.
एक मिनिट, आता हे शेअर कसं करायचं?
सर ओपन करून घ्या स्क्रीन आणि शेअर वरती जा. स्क्रीन एक साईडला ओपन करून घ्या फक्त.
ओपन तर केली.
ओपन करून घ्या आणि शेअर वरती क्लिक करा. याच्यात जाऊन झूम वरती.
अच्छा, झूम मधून का?
झूम मध्ये त्याला एक साईडला ओपन करून ठेवा. मिनिमाइज करून घ्या याला स्लाइडला.
हो. आणि
झूम शेअर करा.
झूम वरती हाईड स्लाइड व्ह्यू नॉन
शेअर
शॉर्ट.
वरती करा. तिथं येईल स्क्रीन, तुमची स्क्रीन दिसेल त्याच्यावर सिलेक्ट करून शेअर करून घ्या.
ओके. आली?
2 मिनिटं सर. हो सर.
ओके.
सर इंट्रोडक्शन देतो मग सुरू करून द्या. टेक्निकल टीम प्लीज गो लाईव्ह.
Yeah, we are live.
Yeah. Hello everyone. This is Dr. Tejas Rane, MD Medicine, practicing in Jalgaon since last 5 to 7 years. So our topic today is carbohydrate effect on glycemic variability and causes and treatment. So if you see more than 100 million patient in India are diabetic, in which each up to 44% and are in 4 years. So if you see 36% have hypertension. And so uh, out of the latest update of 2025, 5,589 million adults are living with diabetes worldwide. In 1 in adult in globally has diabetes. The number is projected to rise up to 853 million by 2050. 81% of adults with diabetes live in low and middle income countries. Diabetes causes 3.5 million deaths in 2024. So, um, uh, so causes of rapid rise in diabetes in India. Doctor wants high carbohydrate tradition Indian diet with white rice, refined wheat. It increases your diabetic risk. So these are some articles. Millet instead of white rice. Why this switch won't work if you don't cut carbohydrates or add proteins. So no carbohydrate causes of rapid rise in diabetes in India. So main in risk factors: increased calories if glycemic load, decreased physical activity, urbanization, and depression. And so these are the four or main risk factors. So change in dietary habits, it's often decades, is increase in consumption of processed food, imbalance and by the way, energy intake and expenditure on day-to-day basis. So impact of carbohydrate intake on glycemic control. Indian diet deserves 62.3% of total energy from carbohydrate, predominantly from refined cereals. Carbohydrate intake was associated with 14% high risk of type 2 diabetes, 15% in high risk of pre-diabetic. Refined carbohydrate and added sugar showed stronger association with adverse glycemic income. Replacing in carbohydrate with protein in was associated with low glycemic control. So, supporting evidence as from Indian prospective study demonstrate that adoption of low carbohydrate diet in adults with type 2 diabetes is associated with favorable glycemic and metabolic improvement. The dietary intervention was linked in to improve glucose radiation regulation along with it, it beneficial changes in overcoming metabolic profile. This uh, these these finding complements national observational data by suggesting the reducing carbohydrate intake by making therapeutic value of type 2 diabetic management. And together, this study emphasizes the low carbohydrate quantity and quality are important determinants of glycemic control. The relationship between dietary patterns and so in this patterns and glycemic variability in people with impaired glucose tolerance. So positive correction was observed by glycemic variability and high carbohydrate diet. Negative correction and with low glycemic index and protein intake. GV worsening with an increase in overall daily carbohydrate and refined grain consumption and improved with increase in whole grain intake and IGT. So cardiovascular and kidney risk reduction. So this is the chart pharmacological ADA 2026 guidelines, in which they have shown very much a effect of BD dosing over OD dosing OD in GV control. So so this is a multi-center open label study to access as effect of remogliflozin on glycemic variability as compared to dapagliflozin using continuous glucose monitoring. So it is a randomized two-arm parallel null group open label 6 week duration, and so in which effective objective was to evaluate effect of remogliflozin on 24 hours glucose profile is assessed by parameter derived with continuous glucose monitoring in Indian patient of type 2 diabetes mellitus. So this is the study flow. So mean change in continuous glycemic profile across 24 hours of baseline or to phase 1. So this is PP glycemic in independent risk factor for CV and for showing the further increase in the risk of CV events in diabetic patient. Indian meal pattern of high carbohydrate meal per day contributes to more PP hyperglycemia results. Significant improvement in ITR and HbA1c level with both the groups, but not a difference between the groups. Significant improved in post-prandial glycemic parameter, that is MPPGE, P1 hour and PP2 hour with remogliflozin, but not significant with dapagliflozin. So similar adverse effect was found in both of the groups. Use of LGL2R and DPP4 combination in GVR. So effective and safety of combination of remogliflozin in ethocarbonate and vildagliptin in fixed doses with patient with type 2 diabetes mellitus, a randomized active control double-blinded study. So this is significant changes from baseline in FPBG and PPG level. So this was the objective in which inclusive criteria was age less than 18 years and more than 65 less than 65 years was either gender diagnosed with type 2 diabetes for more than 6 months for daily metformin doses of 1000 to 2000 uncontrolled glycemic with HbA1c less than 8 at the time of screening. One second. Huh? बरोबर 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 patient willing to provide signed and dated return on consent. So this is the summary in which there was significant blood pressure and weight reduction over 24 weeks with treatment of FDC and RMC. So safety of remogliflozin in comorbid condition. Remogliflozin in patients with type 2 diabetes is hospitalized with acute decompensated heart failure. So Remo says a heart failure. So monitoring recording of adverse effect, serious adverse effect. So this was the summary. Effective assessment. Effective assessment consisting of rate of worsening of heart failure, re-hospitalization of heart failure, or death at 90 days. Reduction in NT-proBNP at 90 days. Changes of dyspnea accessed by NYHA class. Worsening of renal function undefined with proportionate of portion of patient with further increase in of less than zero point 0.3 mg per dl in serum creatinine in at day 3 compared to baseline at end of follow-up. So comparing the reduction of NT-proBNP between baseline to discharge in 3 months of follow-up. So summary of 2D echo parameter. Left arterial size decrease is by 3.3331 millimeter to 3.23 millimeter in remogliflozin and conventional arm respectively from admission to third month follow-up. Left ventricular mass decrease by 1.56 gram and by 0.92 gram in hemoglobin and conventional arm respective from admission to third month follow-up. So conclusion, an initial remogliflozin in AHF patient did not uh, increase the incidence of acute kidney injury or hypotension or hyperglycemia. In patient with acute decompensated failure, a reduced ejection heart failure, remogliflozin was well tolerated without any significant adverse effect. Anti-proBNP level improved significantly in both groups, but percentage decline observed with remogliflozin was greater than conventional therapy group, both at discharge and day 12 weeks. Novel evidence of hemogliflozin in chronic kidney injury patient. So this is a randomized control 6-month trial therapy. So these were the results in which p value was significant. And so, if you compare Remo and dapagliflozin showed similar consistency, safety, and efficiency in result of renal and glycemic parameter in type 2 DM and CKD patients. Sustained decrease in estimated GFR at 50% or reaching end-stage kidney disease was similar to both groups. Remogliflozin was found to be well tolerated and non-inferior to dapagliflozin in patients with type 2 diabetes and CKD. So Remo has 9 Indian studies with 44,000 plus Indian patient data. Thank you.
Thank you, sir. Now session open for question and answering. Anybody have a doubt or any question, please free to ask.
Yes.
No question. Thank you, sir, for
Thank,
wonderful session.
yes,
Thank you for giving your valuable time. Thank you, sir.
thank you, thank you. Yes.
So with your permission, can I conclude? Thank you so much.